Hello, my name is Kelly Nastasi, and I'm a student at Loyola University in the Masters of Nursing Healthcare Systems Management program. I've been challenged with identifying a problem in healthcare today and creating a new technology to address this problem. There is a recent trend in inappropriate ER utilization occurring nationally. The annual number of ER visits increased 23% between the years 1997 and 2007. Emergency departments of hospitals have seen much of the increase as a result of inappropriate utilization and are having to combat overcrowding in psychiatric holdings. This leads to increased wait times, patient complaints, and suboptimal patient outcomes for those patients that go to the emergency room for true emergent reasons. Payers are tracking this patient behavior because it increases ER visits, which are also increasing healthcare costs for their members. Why is there inappropriate utilization? Many reasons have been identified through research, with the main issues emerging of lack of access to providers for non-urgent needs and inadequate education on appropriate reasons for emergency room visits. The National Hospital Ambulatory Medical Care Survey uncovered that in 2006 there were 119.2 million emergency room visits, and only 15.9 million of those visits were categorized as urgent. This discovery means that in 2006, 103.3 million emergency room visits were unnecessary and not for emergent purposes. With the HIPAA and HITECH Act, more providers are interested in appropriateness of care since quality is now tied into reimbursement. Also, as more providers are turning to value-based proposals, the cost-effectiveness of care is an important consideration. Insurance companies are feeling the effects of higher costs of health care and decreased Medicare reimbursements. There lies the target populations, providers and insurance companies. Utilizing a quality tool to assist with this national problem will help the insurance company meet the metric of decreased utilization while improving health outcomes of its members, which will in turn aid the reimbursement to providers. Of course, the other target population and end user of the product is the patient. This tool would empower them to help manage their own health care. Activating a patient to learn how to manage their own health care results in more positive and healthy behavior, which in turn decreases inappropriate ER usage. Is there a current practice aimed at combating this issue? The answer is yes. There are numerous interventions being employed to aid in decreasing inappropriate utilization of the ER. There are nurse phone lines through hospitals and insurance providers that are available around the clock to be able to address any questions that a patient may have. There are after-hour lines used by provider offices to answer any questions that arise after office hours and are addressed by a licensed professional if necessary. Finally, there are urgent cares popping up all over cities in the nation. These facilities are present to assist patients in getting the care they need when access is a problem and their primary care provider is unable to see them. So many solutions. So why does inappropriate ER utilization continue to rise? Often the nurse care lines and provider after-hour lines tell patients through recorded lines and messages that if they feel it's an emergency, to go to their nearest emergency room. What happens when the patient doesn't realize that their issue truly isn't an emergency? They arrive at the ER door anyway. What about urgent cares? There are often higher copays at these types of facilities than there are with ERs. ERs will delay copays until a later date because legally they cannot turn people away. The urgent cares have the ability to request payment up front, just as a doctor's office does. Again, an issue for those less fortunate patients. I propose this solution, that a smartphone-based application be created and accessed by patients so they can determine through the use of this app what their next action should be. The patient would input their symptoms, and through simple analytics of the application and a location sensor on the device, the app would tell the patient whether they should go to an ER, go to an urgent care, or call their provider's office. Through the locational settings on the smartphone, a list of providers would be given based on the proximity to where the patient was at the time of the app's use. Settings within the app would allow the patient to input their insurance provider's information, so participating providers would be the ones showing on the display. The app would also be issued using a passcode from the provider's office. This way, the primary care provider who is interested in higher reimbursement through quality care can be engaged in these issues. The cost of this app would be billed to the provider, so it wouldn't be incurred by the patient. The doctor works with the developers on what individualized, symptom-based settings he wishes to be in place for his practice, which would direct the patient to the desired care setting. Another benefit would also be available. Once the use of this app occurs, a referral transfers to the nurse practitioner or nurse within the practice to follow up with the patient during normal business hours. This nurse could address the issues, ensure the quality of the instructions given to the patient, take care of any needs that may have arisen from the situation, and also ensure for proper instruction related to ER utilization for future purposes. This would ensure compliance as well if the patient received the instruction to call their MD instead of going to the urgent care or ER. Evidence has shown that patient activation can assist in identifying the trend of medication compliance, hospitalization, and ER utilization in the chronically ill population. The efficacy of the new technology would be verified by a provider team that would meet quarterly to address any quality concerns that may have come about in regards to the redirection of members to call their MD office or go to the urgent care or primary care centers. Case studies will be gathered by the nurse, who makes the follow-up calls the following business day, worked up and discussed in a grand rounds type process. These meetings will discuss whether the settings for the analytics within the app need to be changed related to additional concerns or quality issues. The MD office will partner with the insurance company to pull their emergency room claims on a quarterly basis. This will determine if the solutions are creating a decreased ER utilization for their members. This is the desired outcome, and those metrics will show whether the implementation of the app is successful or not based on whether the benefits seen outweigh the cost to the provider office. The app would be marketed to the insurance companies and provider offices. A marketing consultant would make visits to explain the application and its benefits. The insurance company could be useful in this realm because they often have close partnerships with those providers who have value-based proposals, which create risk of cost at the provider level. For providers who are having problems reaping the benefit of this type of contract, the insurance company would be able to offer a contact in the marketing consultant for the app. This consultant would also be a touch point for any issues after the software app is in place and being used by the provider. Increasing ER utilization has been a healthcare issue realized for many years. It is a multifactorial problem. However, if tools can be created to address the factors, then decreased healthcare costs will be realized. Since this is a multifactorial problem, a multidisciplinary solution must be employed to make any kinds of gains. Thank you.